Good evening. My name is Keith Synnott, and I'm a spine surgeon in Kappa. And I was asked to talk about a spine surgeon's perspective on what to do about back pain. There's an awful lot of really kind of sexy and cool surgical equipment and kit about the place. And if it's all right, I'm probably really not going to talk too much about surgery at all because, well, that stuff is all kind of vaguely interesting. And I suppose when you get to my stage, you realize that the difficult thing about surgery for back pain is not deciding when to do it, but really deciding when not to do it. Because unfortunately, most surgeons will have found themselves faced with a situation like this and the various complications of what can be relatively unpredictable kind of surgery. And so I suppose you don't need me to tell you that back pain is a very common problem and it costs patients and doctors lots of time and lots of money. Unfortunately, it can cause a lot of physical and emotional suffering, again, both for the patient and unfortunately sometimes for the doctor. And we're probably all familiar with this sensation with faced with patients with back pain. And even somebody like me who kind of makes a career out of looking after people with back pain, sometimes this is the sentiment that I'm kind of faced with. But it probably is important to recognize that because perhaps a lot of people do have back pain, an awful lot of people can be helped. And often they can be helped relatively simply with very simple advice, very simple management without recourse to some of the kind of techniques that perhaps I spend my time worrying about. And throughout this talk, I'll refer to a few publications, but they're not kind of journals from the Lancet or the New England Journal or anything like that. The things that are a little bit more accessible and perhaps because of that, a little bit more understandable and probably in truth, a little bit more useful. And one thing that I often will refer patients to is this kind of article that appeared 2 or 3 years ago in the Irish Independent, which was described 10 myths about back pain and what to do about it. And I really found it a very useful thing to read because it explained an awful lot of stuff that I thought of intuitively, but didn't always explain. One thing to tell patients who will often come almost insisting on scans is that they're not always needed. In fact, they're seldom needed. And we'll talk a little bit more about when to order a scan and how to interpret a scan. But it is important to remember that scans willy-nilly can be a little bit harmful because they can put things in people's minds that are not necessarily helpful for them. Another thing that people assume is that the back is particularly vulnerable to damage. It's very easy to hurt it, but that's not completely the case. You just need to kind of watch a rugby match to realize what people can put their backs through and think back through the history of time. If our backs were vulnerable to damage, we never would have survived and developed on an evolutionary basis as time went by. So really, this isn't completely true. And people often also think that the back isn't designed for bending and lifting. And there's an awful lot of time, energy, and in fact, a whole industry has been developed in kind of teaching people how to bend and how to lift things and how to protect their back. And it's interesting, the recent evidence will kind of suggest that a lot of these kind of rules and regulations are not strictly necessary. And the people will often adopt the best way to lift for themselves. And that's not to say that kind of being careful with health and safety is not important. But again, sometimes the degree of paranoia about the back is not necessarily in keeping with the literature. And people will sometimes think that if they have back pain, they must have an injury or there must be some damage or there must be some sinister underlying cause for it. And that's often not the case. Most people will have some back pain. And if you investigate them, you'll find that there's no specific injury. And again, we'll talk about that. But it's not necessarily the case that an ache in the back is some great harbinger that there's some substantial or significant thing going on. The other thing about back pain, and it's kind of passed away now, thankfully, is that it used to be a case that people were advised when you got back pain to go to bed, take rest, let things settle down. That's not the case anymore. When your back is sore, you really need to try and keep moving and keep active. And again, we'll talk about this as we go through. Again, not a great advertising pitch for me is to say that people should not rush for surgery. Surgery for back pain really has a very limited role. And again, I'll talk about this as we go along. Surgery for leg pain is a different thing. Again, I'll speak about that, but certainly it's the case that people with back pain should not be rushing for surgery. In general, exercise is good for back pain. People are often afraid to exercise, and I'll often see people who were very active, got an episode of back pain, gave up their regular activity, whether it was running, cycling, going to the gym, saw me 6, 8, 10, 12 months later, and it's only been bad for them. Exercise is good. People will also often ask what exercise is good, and it doesn't really matter. There are advocates for all kinds of things, yoga, Pilates, swimming, every kind of exercise you can think of. But the truth of it is any exercise is good and no exercise is bad. So if you have a patient who likes doing something, encourage them to continue doing it and to keep active as much as possible. Strong medications are, again, something I'll come back to as time goes by. Strong medications can be good for acute back pain in the short term, the kind of back pain that I give people when I take a knife or a hammer, a chisel to their back, and they'll take strong medications for 24 or 48 hours. Strong medications for chronic and long-standing back pain really don't have a role to play and have been kind of proven to have little effect for chronic back pain. And again, it's something that I'll come back to because it's something I feel quite strongly about. There are a variety of fads and fashions. There are all kinds of complementary medicine techniques that are advised for back pain. And what I'll try and do as we go along is talk about why some of them would work and what kind of attitudes we should take towards them as we go by. Another thing to remember is that back pain can be cured. People think that once you get a pain in your back, that's it, you're done forever. But the natural history of even chronic back pain where you have a significant underlying cause, is for it to improve. So in most people, back pain will get better over time rather than getting worse. One thing which I often tell patients and spend a lot of time talking to them is about what I call the uncertainty of back pain. And people will often like to be given a label, and doctors always like to tell somebody that they know what's going on and what's wrong. And it becomes very hard for doctors to say to a patient, I don't know what's wrong with you. Equally, it's hard to say, I don't think I should do anything about it. But this is the reality of managing lots of people with back pain, and I'll explain why that's the case in a second. The thing about this uncertainty and the thing about saying I don't know is to be certain about it. And I know that seems kind of paradoxical, but with a little bit of knowledge about the natural history of back pain, I think it's something that we can adopt, and we can get people around the difficulty of where they see several different clinicians of a variety of hues, all of which will feel the necessity to give them a label, give them a diagnosis, and multiple differing diagnoses can often cause confusion. And I like to think about something that I call the kind of the 80-20 rule. And really what I mean by this is that what we know is that about 80% of cases of back pain are non-specific. No focal cause is found. So it's normal for a patient with back pain not to have a diagnosis. If you don't reach a diagnosis or decide somebody's pain is non-specific, you're in the majority, not the minority, and it's not something that we should feel guilty or bad about. And trying to avoid being in this 80% is often the reason why people get given diagnosis, which can cause more confusion. Another thing about back pain is that 80% of it is self-limiting. No matter what you do, it will get better if you wait. And this is the case, as I say, in kind of 4/5 of people with acute back pain. And this is the reason why some fads and different treatments become popular, because if you apply anything and you use the natural history, which is for spontaneous improvement, it will get better in 4/5 of cases. And for lots of treatments, if we had an 80% success rate, we think that it was very successful, we'd use it all the time. And really that's what's happening an awful lot. So again, with lots of patients with back pain, you can say, look, I don't know what's causing it, but it's probably non-specific. And there's a very good chance it'll get better no matter what we do. Another thing to remember is that 80% of all scans ordered will show an abnormality. It's exceptional to see a normal MRI scan. You'll nearly always see some little minor abnormality. I often say it's a bit like taking a microscope to everybody's skin. You'll always find a spot or a blackhead or something somewhere, but it's not a problem. It's not causing an issue. So when you send somebody for an MRI scan, it's relatively easy to say to them, your scan will show an abnormality. But the trick is deciding whether or not the abnormality is A, accounting for your symptoms, and B, can have anything done about it. So again, it's something where you can try and get an easy win by reminding patients of this. And from my perspective, what I find is that about 80% of people who refer to me as a spine surgeon, I can't do anything for them. And these people are often very disappointed because they get the idea that I'm some kind of an expert in back pain, but I'm not. All I do is treat those few patients who have a cause of their back pain that can be helped with surgery. The vast majority of people don't need surgery, so I'm not in a position to do very much for them. And when managing back pain, despite the fact that I've said a lot of it is non-specific and will get better, it is important to make sure you don't miss something big. I often said to people before that, my ambition was to write a book. I think they say that everybody has a book in them. And my book was going to be the fuck up book, which was things that you don't want to avoid and don't make any problems with. And this is very much the case with back pain. So there are a few conditions that you must make absolutely sure are not present when you see somebody with back pain. One is called Aquinas syndrome. One is cancer. I have a patient at the moment who presented to me with acute back pain. I treated them sometime in the past. They had an MRI scan of the lumbar spine. It was normal. It turned out subsequently that they had a tumor which involved a part of the spine not seen in the MRI scan. So even with all the best will in the world, it's easy to miss. And we'll talk a little bit about that. And finally, there are kind of unusual causes of acute back pain, such as an aneurysm, sometimes kidney stones, that need to be considered. Although, as I say, they really are very unusual. We'll all be familiar with the red flag symptoms of cauda equina syndrome, and every single patient I see gets asked about bowel and bladder dysfunction. They get asked about perianal or perineal sensation. But one thing that people will often forget when considering cauda equina syndrome is bilateral radiculopathy. If somebody has sciatica affecting both legs, that infers a disc or something else big enough to impinge the nerves on both sides of their spine, and therefore probably the nerves in between. So if you see somebody with bilateral sciatica, symptoms in both legs, that's a red flag for cauda equina syndrome. While we talk about PR examinations and careful clinical histories and trying to be careful to make sure you don't miss somebody with cauda equina syndrome, it's really important to remember that history and clinical examination are neither sensitive nor specific enough to definitively outrule cauda equina syndrome. There are false negatives and there are false positives. And a rule that I try and teach all our junior doctors is that if anyone, physio, GP, casualty officer, orthopedic reg or SHO, anyone thinks a patient might have cauda equina syndrome, they need a scan. They need an MRI scan. It's the only way to avoid missing cauda equina. You have to accept that a significant number of scans will be normal. Loads of normal scans are better than missing cases of cauda equina syndrome. I know this is a standard that's very hard to keep, and it's easy for me to say as somebody who works in the matter where you have 24 access to MRI scanning. But I think it's important that we all advocate for the fact that just because MRIs are hard to get doesn't mean they shouldn't be done when they're appropriate. Cancer is another cause of back pain that we don't want to miss. It's important to remember that the commonest organ that a tumor metastasizes to is the bone, and the commonest bone it goes to is the spine. So it shouldn't be surprising that vertebral metastases are relatively common. And in fact, vertebral mets are one of the things that take up most of our workload inside the matter rather than injuries. In the matter, about half the patients that we see who are paraplegic from cancer, it's their first diagnosis of cancer. They never knew they had a problem beforehand. Another time we spend our time trying to find out what the primary is. Again, we're all familiar with the red flags. Somebody who has a history of cancer, somebody who has weight loss, unremitting pain, pain that's not getting better, that's not obeying the 80% rule saying that the natural history is for improvement. You need to scan them and look to try and make sure they don't have cancer. In the UK, the NICE guidelines are that anybody with a history of cancer with new onset back pain gets an MRI scan within a week. Again, something that's difficult to realize here, but just because it's hard doesn't mean we shouldn't think about it. And from our perspective, in terms with surgery, it is far, far easier to manage somebody with metastatic spinal cancer before they get paralyzed rather than afterwards, because once their neurology develops, the ship has pretty much sailed. I mentioned rare causes, things like aneurysms. Again, very difficult to diagnose, but every now and again, you do see somebody who presents with a dissecting aneurysm and sudden back pain. Truthfully, it's probably a case that you're only going to diagnose as in somebody with a known aneurysm that's being monitored or develops back pain, but possibly is something you should consider in somebody who's got known risk factors and is a vascular path. Now I'm going to talk through some relatively common clinical scenarios, just as I say, to give my perspective on how to manage them. Things like acute chronic back pain associated with leg pain, which, as I said, is the kind of thing that interests me to a greater degree. And I'll mention deformity and a couple of other causes of back pain. You'll often see these big, long lists of back pain, which make things seem exceptionally complicated and suggest that you need to think about all these diagnoses. But really, I'm not sure that that's the case in all circumstances. A common presentation would be somebody who's got acute low back pain. It's sudden onset, it's severe. It's what gets me to call around to my friend's house when his wife can't get off the floor because they're in agony. People are in bits. There's often just a twist or a turn, or they were doing some gardening, but no other, or perhaps no precipitating event. And it can be recurrent. It can happen every now and again. Often people will have a background of back issues. They know this is happening every now and again. And really it can be quite severe and quite discomforting. And patients are often very concerned and very afraid about what it suggests and what's going on. First thing to do is to rule out a sinister cause. Again, avoid the fuck-ups, look for cauda, look for cancer, look for other things. But generally speaking, acute back pain with somebody with a list tilted off to the side is caused by muscle spasm. When you say that to patients, they often think you're talking through your hat because this pain is so bad they can't imagine that it's caused by muscles or spasm in the muscles. So sometimes it's useful to remind them that the conditions that are commonly believed to be the most painful, childbirth, kidney stones, are caused by smooth muscle spasm. So the fact that your big extensor muscles in your back, when they go into spasm, are very painful shouldn't be that surprising. You can often reassure patients, short-term analgesia and muscle relaxants, not long-term, short-term for 24, 40 hours can be useful. Again, as I mentioned earlier, taking to the bed and resting is not the best thing. And encourage people to mobilize little often, as much as they can. What will often happen is this pain will settle in a day or two, or even a week or two. And what people then do is they tend to get relaxed and relieved, and they think this is great, everything is hunky-dory, and they do nothing about it. But what I often say is the time to mend the roof, or the time to try and stop it happening, is when the sun is out. So when your pain is settled, then you go for physio, you do exercises, you do whatever is required to try and keep your back muscles in condition so that they're unlikely to go into spasm or fatigue again. Again, like the footballer who doesn't want to get cramp at the end of extra time, he gets fitter. So if you get your muscles fitter and stronger, it's less likely to happen. If somebody is very frequent or prolonged or significantly recurrent acute back pain, that's the time to try and to investigate, to look further. You, as I say, manage expectantly initially. If it's not resolving, if it's very recurrent, then you look about investigating further. Another very common clinical scenario is chronic back pain. The person who comes to the office or the clinic over and over again with low-grade, long-standing, won't get better back pain. And really, this is a very complex condition. And it's complex for two reasons. One, because the spine is complex. There's multiple motion segments, there's multiple nerves, there's joints, there's discs, there's muscles. There's all kinds of things going on which can contribute towards this sensation of back pain. But the other thing that makes it complex is that it is often on a background of significant psychosocial issues. So often people have something underlying which kind of accentuates their tendency to catastrophize or have a bigger problem with pain. And sometimes it's the case that having chronic back pain basically wrecks your head. So there's always a psychosocial element to somebody who's living with significant chronic long-standing back pain. With these patients, I think it's very important to gain their confidence. I mentioned earlier on, often the presence of pain doesn't indicate something very sinister or serious that's underlying it. Often the presence of pain doesn't mean you need to be excessively careful or cautious. It doesn't mean that you got to avoid the activities that you like, be they sporting, recreational, whatever else it is. It's important to consider the alternatives for chronic non-specific back pain. But again, I think it's relevant to set the stall out earlier. So when you say to somebody in advance that you don't necessarily expect to find something sinister, something severe, something that requires aggressive intervention, often you can buy confidence when that proves to be the case as time goes by. Another publication that I sometimes refer people to is this book called Crooked, which was a book that was written by an investigative journalist with chronic back pain who sought surgery to manage it. As a result, she looked into all the various treatments that were available for people with back pain and looked to try and see exactly how they stood up against the literature. It's a really phenomenal book, and it's really interesting. It's well worth a read. People like me, spine surgeons and people who inject people, don't come out of it very well, I'll be honest with you, but really it's a great book and a great read for patients and for doctors. Again, we talk about the pain generators, and I mentioned the complexity of the kind of the spine and what's in it. And people will wonder, can the discs, can the facet joints, the SI joints, nerves, bones, muscles, all of these things contribute to back pain. And often trying to distinguish which of them is the source of your pain is difficult. And sometimes it's not actually necessary. People wonder about degenerate discs and talk about discogenic back pain, but the truth of it is that discs are often degenerate. Just like your skin gets dehydrated and wrinkly, the same thing happens in your back as you age. But truthfully, discs are seldom painful. We used to think that injecting discs with dye and reproducing pain was an indication that they're painful, but really things like discography, the utility is not so certain and not so clear at the moment. While the disc might be part of a complex problem, it often isn't the only solution. And that's kind of a good thing, because if you believe in discogenic back pain, currently the state of art of surgery is a spine fusion. And fusing somebody's spine to address their pain is the equivalent to doing what you can see in the picture on the right to make a car safer. Yeah, it's not going to move or go anywhere, but it's not much use to you. So again, the role for spine fusion, for discogenic or for pure back pain is really very unclear and very uncertain. People wonder about the facet joints as being the cause of pain, and often complementary healthcare providers will diagnose facet joint disease. And I'll often see people who've been told, somebody poked my back and said my L2-3 facet joint was the source of my problems. As somebody who regularly puts my finger on somebody's spine and says, I think this is L4 or L5, then puts a knife in it and puts a wire in it and takes an x-ray, it's very hard to be sure where you're palpating. So I'm always a little bit skeptical about these things. And while facet joints are often blamed for the pain, it's not quite so clear that they're always the cause of the pain. Clinically, if somebody's pain is reproduced by extension, in theory, that's compressing their facet joints, and it might indicate that they are the source of the problem. But as I say, it's not a very black and white cause and effect type thing. Things like injections or rhizotomies, where you use a radiofrequency probe to ablate the nerve to the facet joints are described as ways in which you can treat facet-mediated pain. Again, I'm somewhat skeptical about some of these things because they're relatively simple, relatively low risk things for a common problem. And it's not always easy to know how useful they are. And just like everything else, time, exercise, activity is probably the most efficient thing for managing facet joint issues. One thing about the facet joints, and we'll talk about it later, is when they become very arthritic, you get a lot of bony swelling, and that bony swelling can reduce the space available for the spinal cord and the nerves, and that can cause back pain with associated leg pain. So while the facet joints may not necessarily be a significant cause of axial back pain, in time they can cause other problems with leg pain. The sacroiliac joint is often blamed as a cause of back pain, and people are often told their sacroiliac joint is out of alignment. It's important to remember that the sacroiliac ligament is the strongest ligament in the body, and this is a really stable, really stiff joint. It's very hard to put it out of place without crashing a car that's going faster and falling from a high building. Facet joint or SI joint pain can, however, happen in an inflammatory issue or inflammatory problem like ankylosing spondylitis or one of the other spondyloarthropathies. And I recently was at a talk by a rheumatologist who showed how that ankylosing spondylitis usually is diagnosed after 15 to 20 years of symptoms. So something that we often don't recognize. She was advocating people who are suspected or possibly might have say ankylosing spondylitis should have an HLA-B27 test, which she felt was relatively cheap, relatively easily available, and sensitive and specific. So it is important to consider the possibility of inflammatory conditions, again, in patients whose symptoms don't get better, who are recalcitrant, or may have other associated inflammatory conditions, such as psoriasis, uveitis, or inflammatory bowel disease. People with significant back pain often think that it's because they have a pinched nerve, and I'll often hear this. The acute, sudden, severe nature of acute back pain often leads people to believe that they've got a nerve issue. But truthfully, most of the structures in the spine are poorly innervated. And when I think about neurogenic or nerve type pain, I'm typically thinking about radiculopathy or sciatica, which again, we'll talk about in a second. Another thing people will wonder about when they've got chronic back pain is it because they have something like osteoporosis or osteopenia? And while this is a significant problem that should be diagnosed, it's important to remember that osteoporosis isn't painful unless it leads to a fracture. Certainly, some patients, particularly older patients, ladies, if they're underweight, if they're smokers, if they have other risk factors for osteoporosis, develop acute pain, perhaps with no specific precipitating factor, may have sustained an osteoporotic fracture, and it's something to consider. And again, it can be usually treated expectantly. It will usually settle promptly, and it's only if the symptoms don't resolve or if there's associated features such as neurological deficit, which is really rare, that further investigations is necessary. Exceptionally, you'll see patients who get osteoporotic fractures that don't settle, who might benefit from cement augmentation, where we inject cement into the vertebral body to stabilize it. This was something that was very popular, but again, recent evidence would suggest its role is relatively limited. The final common denominator of all these potential sources of pain is your muscles. Your muscles are stabilizing your spine. They're controlling the movement and how things move at the time. They're always working, and they're frequently painful. Anybody who does any activity the whole time or carries something for a long time will get muscle ache and muscle fatigue. And it's probably the case that most back pain is muscle mediated, even if there is something underlying it. The fact that the muscles are being asked and activated to try and stabilize the spine is the reason why people get pain. I think it's important to explain this to people because often when you refer them for physiotherapy or suggest exercise, they wonder why exactly you're doing it. And if there's a good rationale for it, people think that you're taking their symptoms seriously and that there's a likelihood that things will kind of make a difference and get better over time. And finally, people will often feel when you refer them for physiotherapy or feel when you suggest that it's non-specific back pain or suggest that there's no specific management or encourage them to remain active, that you're saying their pain is all in their head, that you're making light of it. Whenever I'm told that some patient feels I said it was all their head, I know it's not true because it's about the most offensive thing you can ever say. And certainly things are never all in their head. But I think it really is important to remember the effect of chronic pain. And again, I said earlier on, the cause and effect issues that take place. It's important to reassure people. It's kind of a form of psychotherapy. I would never suggest that I'm a psychotherapist, but sometimes I do believe that if you can explain things to people, it tells them that you're taking it seriously, and it buys their confidence in what you're kind of suggesting as time goes by. I mentioned earlier on my thoughts on strong painkillers. And again, this is another book that's worth reading about the opioid epidemic in the United States. And I always feel sorry for primary care doctors who have at their disposal very strong painkillers, such as opiates, when they're faced with patients who are in a lot of pain and are looking for something that can help them. And certainly there is a short-term fix with strong painkillers. But if you read books like this, it gives you a background to how it came to be that patients have an expectation that very strong painkillers will be prescribed, and also the effects that it can happen. I just saw an ad recently for a Netflix documentary about the same topic. So it's something that's becoming kind of more widely aware of. And a stat that kind of struck me about this was that apparently within the last 5 to 10 years, for the first time in history, life expectancy in the United States is falling. And they say it's explicitly because of the risks of overdose of opioids, which will give you an idea of the scale of the problem. There are some surgically addressable causes of low back pain, and patients can have instability in their spine. They can have a deformity in their spine. They could have a tumor or an infection, or they may have a fracture. But these causes of back pain are relatively uncommon, and they're usually diagnosed when you have initially tried non-operative management, tried to manage people conservatively. And as I say, sometimes what you need to do is say to somebody, I want you to keep mobile, I want you to go for physio, and we'll see how you are in 6 or 8 or 10 weeks. If things aren't settling, it may be worth investigating at that stage, because there may be one of these uncommon surgically addressable causes of low back pain. And having spoken a lot about things for which surgery has little role to play for, I'd now like to talk a little bit about things where surgery can have a role. I'm a bit of a pedant, and I get told by lots of people that they have or have had sciatica. And to my mind, sciatica can mean lots of different things to different people. Often it means acute low back pain with muscle spasm. Occasionally it does mean leg pain, but it can mean all kinds of different things. So I usually talk about lumbar radiculopathy, meaning a problem with a nerve root causing pain or paresthesia or weakness in the distribution of that nerve root. Most commonly, it's caused by a prolapsed intervertebral disc, and most commonly, it's one of the lowest 3 discs, because they're the ones that take the greatest load. There's more weight and more body above them. Because of that, most commonly, a true lumbar radiculopathy will cause pain or pins and needles that goes below the knee, because that's where the L4, the L5, and the S1 nerve root innervate. Patients with this condition may have some prodromal back pain. They may have associated paresthesia. They may have associated weakness. Always be careful and always kind of go back to the A, B's, and C's and think about things like cauda equina syndrome. But again, remember the 80-20 rule applies. Even if you've got somebody who's got a prolapsed disc with significant sciatica, the same thing applies. 80% of people will get better of their own if you wait long enough. That's an appropriate treatment. Patients will often have a typical history, a bit of a twist, a bit of a pain in their back, and then they develop leg pain. You can often see some specific and sometimes relatively pathognomonic clinical signs. Patients will often have a list like the photograph shown here. A patient is tilted to the side. This is a different thing to a scoliosis. In a scoliosis, often there's a curve in the back, but your head is above your pelvis. With a list, your head is tilted off to the side. And this represents muscle spasm and the lumbar extensors on one side rather than the other, pulling it off to one side. People will often talk about straight leg raising. Usually this is done with somebody lying on their back and you lift their leg, and that's often a painful thing. I will always examine for straight leg raising with the patient sitting on the edge of the bed with their knees bent over. If you perform a straight leg test, and if you get contralateral positive, so if you have a patient with left leg pain and you do what's shown in the picture here in the right leg, and you get a reproduction of the pain in their left leg, that's almost pathognomonic of what the problem is. And it's a very simple test to do. And as I say, it can be very, very sensitive and specific. Checking for motory and sensory reflexes or exam is useful. People will often find that they don't get a positive test, and often it's because of the way in which they've been taught to do a neurological exam in medical school. So we've all seen this kind of figure of 4 position that's kind of recommended for testing ankle jerks, which is something I always find very difficult. It's much easier to test an ankle jerk like this And this video actually shows one of my sons testing the ankle jerks of my other son. So again, not a terribly difficult thing to do or to test. And again, you can test motor sensation relatively easily. And people can have weakness of their ankle plantar flexors. And if they do have, or dorsiflexors, they won't be able to walk on their heels like that. They can have weakness of their ankle plantar flexors. If they can, they won't be able to go up and down on one leg. And very rarely you could have weakness of your knee flexor, knee extensors, which means you can't go up on a step like this. Again, easy tests to do and very sensitive. If somebody has a lumbar radiculopathy or sciatica, surgery can be indicated, but not always. As I said, 80% of people will get better, but if people can't put up with it for another minute, or if they've had it for 6 or 8 or 10 weeks, they don't want to wait any longer, and they don't want to think about injections, which can sometimes be useful, then there are good results to be achieved with surgery. It's one of the more satisfying procedures that we do. If you've got somebody with a big disc and lots of pain, they'll often wake up after their operation, their pain is gone, and they're incredibly grateful. So it can be a very good procedure to do in the right cases. However, it is important to remember that about 10% of people who have a lumbar discectomy will get a recurrence, and recurrence in the setting of previous surgery is a different thing from recurrence in somebody who had non-operatively treated sciatica. So while it's tempting to operate on everybody with sciatica, because a lot of them will do well, it does bring problems down the road, and it is associated with some complications, even if they are relatively uncommon. Spinal stenosis with claudication is another problem we'll often see in patients with back issues. I mentioned people with facet joint disease can get hypertrophy of same, which can compress the spinal canal, particularly if it's associated with disc bulging or extrusion into the canal, or with a slippage of one vertebra over another, causing a pincer mechanism within the spinal canal. Claudication and spinal claudication is often seen in older patients with lumbar spondylosis. And it's important, if you've got somebody who has leg pain brought on by walking and relieved by rest, to think about vascular disease, especially if they've got known vascular risk factors or they've had a history of a stroke or a heart attack. The typical features that distinguish spinal from vascular claudication is that we know with spinal claudication, if you can flex your spine and lean forward, you get relief, whereas if you extend your spine, you get exacerbation of your symptoms. For this reason, people with spinal claudication will often say they must sit so they can flex their spine or slump to get relief from their pain. And similarly, they'll often say that if they can walk leaning over something like a bicycle or like a baby's buggy or like a grocery cart, they get relief of their pain. Spinal stenosis and claudication is very common and it's very treatable. So while older people can find that they can walk less and less, and you think that this is just a feature getting older, often it's not. It's because their back is something that really can be managed relatively simply. And in fact, the results of spinal decompression for claudication are as good as the results from a hip replacement, which is famously the second most cost-effective and second best operation ever invented, second only to cataract surgery. There's loads of techniques that you can use to decompress the spine using microscopes, using fancy tools and things, but effectively, really what you want to do is create more room for the spinal cord and the nerves. Occasionally, the amount of bone and tissue you take away means you need to stabilize the spine with screws and rods, and you need to do a fusion at the same time. But as I say, really the key is to decompress the spine, and the results can be very gratifying. I said I'd mention a little bit about MRI scans because people will often ask about this. Again, remember the 80% rule. 80% of MRIs are abnormal. Tell the patient beforehand, you will have an abnormality. I think it's a good exercise when ordering an MRI scan to have a question in mind. What do you expect to find? Do you expect to see a disc pushing on a nerve because the patient has a lumbar radiculopathy? Do you expect to see spinal stenosis because of their claudication? Do you expect to see a bit aware of a disc, a bit aware of a facet joint, but nothing really, nothing really too bad, and nothing that's likely to require surgery? Or do you expect it to be normal to be able to reassure the patient? People will often feel that a negative MRI scan is a bad thing, but if you've got somebody who's very concerned and very worried and is anxious about going back and doing the exercise that you want to prescribe for them, sometimes a normal or relatively normal MRI can be a useful thing. But again, an exercise I would often say to people is that if you get an unexpected finding, if this is not what you're expecting, it's likely that the finding is nothing to worry about, unless it's something bad like a tumor or infection or something like that. The other thing to be cautious of is when patients read the reports, and that sounds like a desperately paternalistic thing, but often reports will contain things like disc bulge, degenerate, all kinds of words which people get hung up on, and they suddenly think they've got something significantly untoward going on. And again, it can inhibit their ability to try and rehabilitate from their back perspective. So in summary, what I'd say is remember the 80% rule. 80% of back pain is non-specific. You won't find a diagnosis, and neither will anybody else. 80% is self-limiting. It'll get better no matter what you do. And it'll get better no matter what it is. It could be an osteoporotic fracture, 80% gets better. It could be sciatica, 80% get better. Remember tumors, remember cold syndrome, remember the rare things, and avoid them. Don't be afraid to prescribe time. Don't be afraid to say, I'm not going to do an MRI now. I'm not going to do anything different now. We'll give it a month or 6 weeks and see how it gets on, and then we can reevaluate. That's a sensible and noble thing to do. Acknowledge the uncertainty. Say, there may be no single cause. That is normal. That's not unusual. It doesn't say there's something wrong with you, that you've got pain and there's no abnormality or nothing that requires surgery. Take the easy win and tell them you think there'll be an abnormality in the scan, and you can say, look, I was right, by a little bit of confidence. Always consider no diagnosis. Make sure people understand that that's not a bad thing nor an unexpected thing. Always prescribe exercise. Exercise is good, no exercise bad, no matter what the problem is. And I think that it's with these kind of things in mind, it's possible to be confident managing people with back pain. Not finding diagnosis doesn't mean you don't know what's going on. It means you do understand what's going on. And when you're ordering scans and looking for opinions from people like me, preempt them. Tell them what you might think. If you're sending somebody for a consultation with, for example, a spine surgeon, even though you think they don't need surgery, it's worth saying that to them in advance so they don't get a surprise. Don't be afraid to say, I don't know what's wrong with you. That's normal. I don't know what's causing your back pain, because in 80% of people, nobody knows. And I would suggest, if you're reading things about back pain, read patient-centered and not surgeon-centered literature. Again, I would heartily recommend this book. Thank you very much.